Everyone, and welcome back to my channel. Today we're going to talk about diabetes mellitus. It is a common condition that you'll likely encounter, not likely, but you will encounter as you become a nurse and in your nursing career. Our goal is to understand the basics. We want to know what goes wrong in the body, who's at risk, what it looks like when you do have diabetes, what hypoglycemia and hyperglycemia look like, and how we as nurses can treat a patient that comes in with diabetes and go through the whole nursing care process, okay? And we will keep it straightforward. So let's start with a case study. This is Mr. David Rodriguez. He's a 48-year-old male, and he arrived to the emergency room. Mr. Rodriguez is brought into the ER by his wife, Maria, and she states he's just not been himself for weeks, but today he seems really out of it and so tired. He's been drinking tons of water and going to the bathroom constantly. Mr. Rodriguez reports feeling extremely fatigued, thirsty, and having blurry vision. So a little bit of the history of Mr. Rodriguez. Mr. Rodriguez reports symptoms have been gradually worsening over the last 3 to 4 weeks. He initially noticed increased thirst, polydipsia, and found himself drinking significantly more water and juice than usual. He also reports frequent urination, polyuria, including waking up 3 to 4 times per night, to void, nocturia. He initially felt hungrier than usual, polyphagia, but states his appetite has decreased in the last few days due to profound fatigue. He endorses unintentional weight loss of approximately 15 pounds over the last month despite no changes in diet initially. Today, his fatigue is overwhelming. He feels weak, and his vision has become noticeably blurry. His wife notices he has seemed slightly confused today. Now, he has a past medical history, or PMH, of hypertension, diagnosed 5 years ago. He was prescribed licensure, but admits sometimes he forgets to take it. Hyperlipidemia, diagnosed 5 years ago, prescribed atorvastatin, but admits inconsistent use. He's not been compliant with his meds, y'all. Obesity, no known history of diabetes, no previous surgeries. Family history, mother type 2 diabetes mellitus and hypertension, father history of hypertension, died of an MI at age 65. Paternal uncle, history of type 2 diabetes mellitus. Occupation, office manager, diet reports, frequent consumption of fast food, regular soda and processed snacks. Exercise reports minimal physical activity, usually too tired after work. Tobacco, denies smoking. Alcohol, reports drinking 2 to 3 beers on weekends. And illicit drug use, none. Married, lives with his wife, good support system per his wife. Let's go ahead and look closer at what diabetes mellitus is. Let's look at the pathophysiology of diabetes mellitus. So, what is actually happening? Basically, think of your body as needing energy to work, right? So it's like a car needs fuel. The main fuel for our cells is glucose, or sugar. Glucose comes from the food that we eat. The problem is that glucose is floating around in our bloodstream, and it needs somewhere to go. It needs to go into our cells, but it needs some help getting into our cells. So that helper that will help them get into that cell is a hormone called insulin. Insulin is produced by our pancreas, by the beta cells, which are in our pancreas. So the beta cells in the pancreas produce insulin, the key that will unlock the door to the cell for the glucose to go in. So in diabetes, it's basically one thing or the other. There's a problem with either the key, which is the insulin, or the lock, which is how the cells respond to the insulin. This means glucose can't get into the cells easily, so it builds up in the bloodstream, which causes hyperglycemia, or in other words, it's hyperglycemia. So when we talk about hyperglycemia versus hypoglycemia, let's break that down. Here you'll see that hyperglycemia is high blood sugar. Hypoglycemia is low blood sugar. In hyperglycemia, that's basically diabetes. It's the hallmark sign of diabetes. But in hypoglycemia, it is a complication of the treatment for diabetes. So at its core, diabetes mellitus is defined as hyperglycemia. The disease itself is basically characterized by the body's inability to regulate blood sugar effectively on its own, leading to persistently high levels of glucose or sugar in the bloodstream. So hyperglycemia isn't just related to diabetes, it is the fundamental problem of diabetes. So hypoglycemia is, like I mentioned, a complication of diabetes treatment. So it's generally not a symptom of diabetes itself unless it's caused by rare conditions. Instead, it is a very common and potentially dangerous side effect or complication that happens because of the medication that is used to treat diabetes, especially insulin and certain oral drugs like sulfonylureas, meglitinides, I forgot how you pronounce that word, but yeah. Hopefully you know what I'm saying. It results from an imbalance where the medication lowers blood sugars too much. It lowers the blood sugar too much, too fast, relative to food intake and physical activity. So why does this happen? Blood sugars get high because normally blood sugar is tightly controlled. When you eat, blood sugar rises, triggering the pancreas, the beta cells to release insulin. Insulin acts like a key, like I mentioned, letting glucose enter the body's cells for energy or storage, thus lowering the blood sugar back to normal. The liver also stores glucose as glycogen and makes new gluconeogenesis. But insulin normally tells the liver to slow down. It also does this. It tells the liver to slow down the production of glucose when blood sugar is sufficient. So in short, hyperglycemia is the problem caused by diabetes, the lack of effective insulin action. And then hypoglycemia is most often a problem that is caused by the treatment or the tools to fight hyperglycemia. So when those tools or the medications work too well relative to the body's own glucose supply and demand at that moment. Now in this slide, this gives you the criteria for hyper or hypoglycemia. So if you have fasted for more than 8 hours, meaning you've had no food, and your blood sugar is drawn, if it is above 126 milligrams per deciliter, you're going to be diagnosed with diabetes. Now, if it's between 100 and 125 milligrams per deciliter, then you're going to be pre-diabetic. Now, if your blood sugar is taken after meals, 1 to 2 hours after a meal, and your blood glucose is 180 milligrams per deciliter, that is a common target for managing diabetes. If it's a random or taken anytime, your blood sugar is taken anytime with symptoms, then your blood glucose is over 200 milligrams per deciliter. This strongly suggests diabetes. Now, hypoglycemia, if your blood sugar is under 70 milligrams per deciliter, then you're going to want to give the patient some juice, a carb of some sort, and then reevaluate the patient 15 minutes, some would say 30 minutes later, but I've done it at 15 minutes. So that's what you do if you encounter a patient with hypoglycemia. And real quick, let me just discuss and show you some of the signs and symptoms of hypoglycemia. It's not the heart of what diabetes is, which is a focus of hyperglycemia, but it's important to note hypoglycemic signs and symptoms as well, because you will see them in the hospital. Early or mild to moderate symptoms, which are often the first warning signs of hypoglycemia, include shakiness or trembling, sweating, clamminess, diaphoresis, nervousness, anxiety or irritability, rapid heartbeat or palpitations, hunger, dizziness or lightheadedness, pallor or pallor, pale skin, tingling or numbness in the lips, tongue, or cheeks, headache, weakness, or fatigue. And also there are some severe symptoms, which is when your blood sugar drops further and it's affecting the brain. So you may have some confusion or difficulty thinking clearly, difficulty concentrating, slurred speech, lack of coordination or clumsiness, blurred or double vision, drowsiness or the inability to wake up, unusual behavior or personality changes like combativeness, seizures, loss of consciousness, passing out, or coma. And it's also important to note that there is an individual variation with this. Not everyone experiences the same symptoms, and your own symptoms might differ from one episode to the next. There's also hypoglycemia unawareness. Some people, especially those who have had diabetes for a long time or have frequent lows, may lose the ability to feel the early warning signs. So this is dangerous because they might not realize their blood sugar is low until it becomes severe. There's also nocturnal hypoglycemia. This is when there's low blood sugar while you're sleeping, and the signs might include nightmares, crying out, sweating heavily enough to dampen your pajamas or the bed sheets, or waking up feeling tired or irritable or confused. So hypoglycemia is important because it requires prompt treatment. It's usually with fast-acting carbs like the juice box that I mentioned before, glucose tabs, or hard candy. You want to follow the rule of 15. Severe hypoglycemia can be a medical emergency, which is why it's worth mentioning. When I talk about the rule of 15 real quick, this means consume 15 grams of fast-acting carbs, like the juice box I mentioned. Can be 3 to 4 glucose tabs. Check the instructions with everything I'm saying. 1 tube of glucose gel can be, like I mentioned, 4 ounces of fruit juice like orange, apple, or grape juice, but not the low sugar versions. 4 ounces of regular non-diet soda, 1 tablespoon of sugar, honey or corn syrup, 5 to 7 hard candies like Lifesavers, jelly beans, or gumdrops. So do not use chocolate, cookies, ice cream, anything high in fat, because fat slows down sugar absorption, and you need sugar fast in this instance. Wait 15 minutes, don't eat anything else during this time, just let the sugar start doing its thing, and then check the blood sugar after 15 minutes. So recheck your blood glucose level with the meter. If it's still low, repeat the rule of 15 again, and another 15 grams of a fast-acting carb, and then if the blood glucose is now in a safe range, you're good. But also note that this is only for people that are awake and alert and can safely swallow. This is not for severe hypoglycemia. So you will have other steps to follow if it's severe hypoglycemia, like the glucagon injection, which you'll need to push in an IV fast, and it's really hard to push. So in type 1 diabetes, the body's own immune system mistakenly attacks and destroys the beta cells in the pancreas, the ones that make the insulin. As a result, there's little to no insulin that is produced, and the key factory is shut down. The analogy is that if there are no keys to unlock the doors, the cell doors, then glucose stays stuck in the bloodstream. Now, who most often gets type 1 diabetes? Mainly it's diagnosed in children and young adults, but lately it can occur at any age. It's an autoimmune condition, so that's important to note, and it's not caused by lifestyle. So remember that. Now in type 2 diabetes, 2 things are going on. It could be number 1, insulin resistance. The cells don't respond well to insulin. The key is there, but the lock is rusty or it's jammed. The cells resist letting glucose in. There's also relative insulin deficiency. The pancreas tries to make extra insulin to overcome the resistance part, but eventually it can't keep up and insulin production may decrease over time. The key factory basically gets overworked and tired. As a result, glucose is still having trouble getting into those cells, leading to hyperglycemia. Now, who gets type 2 diabetes? It's more common than type 1, so let's note that first. It's strongly linked to genetics, lifestyle factors like obesity, inactivity, and poor diet. And it's usually diagnosed in adults, but it's now increasingly being seen in younger adults or younger people. Now here we have gestational diabetes. You have all the prego women dancing around. But in this instance, this is high blood sugar that develops during pregnancy in someone who didn't have diabetes before. Hormones from the placenta can block the action of insulin, and it usually goes away after birth, but it increases the risk for both mother and child developing type 2 diabetes later on in life. Now, what does diabetes look like? Let's talk about the signs and the symptoms real quick. So high blood sugar causes the classic symptoms. Remember the 3 P's. So your polydipsia, your polyphagia, your polyuria. Polyuria, frequent urination. Why? Because the body is trying to get rid of excess glucose through the kidneys, and water follows the sugar out. Polydipsia, your excessive thirst. Why? Because you're losing fluids from peeing too much, leading to dehydration. Polyphagia, your excessive hunger. Why? Because even though there's a lot of sugar in the blood, it can't get into the cells to be used for energy. So the cells are starving and they send out those hunger signals. The other common symptoms are unexplained weight loss. So more common in type 1 initially, as the body breaks down fat and muscle for energy. And then you have fatigue, weakness, lack of energy, cells aren't getting enough fuel. Blurred vision, your high glucose can affect the eye's lens. And you have slow healing sores and cuts, and frequent infections, your skin, your gums, your bladder infections. You might also have some tingling pain or numbness in your hands or your feet. Neuropathy is often a later sign of diabetes. Of note, sometimes, especially in type 2, symptoms can be mild or develop slowly, and they might not notice them for a long time. Now for type 1 diabetes, you're going to have your family history, a parent or a sibling with type 1 diabetes mellitus. Genetics, certain genes can increase your risk. Geography, it's more common further from the equator. Age, more common in children or young adults. And as I mentioned before, we're seeing it more in older people as well. Important, remember, it's not related to weight or diet. Now, let's talk about type 2 diabetes. Now, your risk factors are overweight or obese, especially if you have abdominal fat. Physical inactivity, those kind of go hand in hand with that. Family history, parent or sibling with a type 2 diabetes mellitus history. Age, risk increases with age. Risk typically increases with age, and it's typically over the age of 45. Ethnicity, higher risk in African American people, Hispanic, Latinos, American Indian, Asian American, and Pacific Islander populations. I am Pacific Islander and I'm also African American, so I guess I got double the risk. History of gestational diabetes, I mentioned that before in the gestational diabetes slide. Polycystic ovary syndrome, PCOS, high blood pressure, hypertension, abnormal cholesterol levels, low HDL, the good cholesterol, and then high triglycerides. So you want your HDL up. You don't want your HDL low. Remember, HDL, happy. LDL is not the one to have high. Pre-diabetes, blood sugar higher than normal. Now let's talk about ADPIE. So the nursing process for diabetes, let's start with assessment. What we're going to do is we're going to first get our subjective data, which is not listed here on this slide.
Next patient.
Yo,
Hello? What brought you to ER today?
real quick, I'm protected by like the HIPAA laws. Like, this is confidential, right? Like, nothing's gonna be said. No, you're not gonna call like my wife.
So you understand that you came here voluntarily, right? And yeah, don't worry. Everything here is going to be private. I'm a nurse. I listen and I don't judge.
Okay, just don't. Please remember that you won't judge. I have.
Whoa. Hold on. What are you trying to do?
It's not what I'm. It's not what I'm trying to do. It's what I was. It's what I was trying to do.
Tell me the story. What happened here?
I was in the garage and my wife was just inside with the kids. We haven't been with each other for a long time, the kids and everything. And
Oh, I cut the BS. Tell me what the hell happened here.
it was dark in the garage. I have the bottle that I thought was the lotion that we have. It was. Have you heard of Gorilla Glue?
You're telling me it's stuck. You got the gorilla grip.
It's been 14 hours.
Now, as for your objective data, which is listed here, you want to know their vital signs, especially their blood pressure, blood glucose levels, finger stick. You want to review the logs, their lab results, their hemoglobin A1C, which shows average sugar over the course of 3 months, average sugar levels in the blood. You want to know their weight, height, and their BMI. You want to assess their skin. So you want to check for dryness, any wounds, signs of infection or slow healing, any sores, especially on the feet. Circulation and sensation can also be impaired, so you want to check for that too. And check your injection sites if they're taking insulin injections, so you want to check for infection and make sure that they're rotating the sites and doing it properly. You want to check their vision acuity, just a basic check. Review their lab results, especially with focus on their kidney function, their BUN, their creatinine. A lipid panel would be good, cholesterol, triglycerides. You want to know all of that. And assess for signs of hypo and hyperglycemia. For your diagnoses, you're going to want to do your labs that I just mentioned, your EKGs, your IV access, your IV fluids, maybe in the orders, insulin and insulin infusion. Insulin may be ordered as well, sub-Q. Now you might get an infusion, but for DKA. If not, it'll be sub-Q. But DKA will be in a whole nother slide or a whole nother presentation, because I want to focus on those emergent types of diabetes, HHA, DKA, or HHS and DKA. Now for planning, you want to plan with SMART goals: specific, measurable, attainable, realistic, and timely. Make sure that you plan to control the blood sugars, educate the patient, and prevent infection. Give any foot care if needed. Now, in the implementation phase, you're going to want to monitor those blood sugars like a hawk. Vital signs, monitor the skin, the I's and the O's. Give them medication, so any oral diabetic medications or the injections sub-Q, and also teach them about the things that they can control. So their diet, assess and see and teach them more about diabetes and managing it and how to give the injection to themselves. Teach them about their medications and when they're supposed to take it, how to take it. If they're doing sub-Q versus oral medications, you want to teach them the safe route or the safe way to give them their own injections without infection and when to give it. Also want to teach them about their lifestyle and the things that they can change, those modifiable risk factors. Foot care, spotting signs and symptoms of hyperglycemia or hypoglycemia, and you want to make sure that they teach back to make sure that they've got it. You also want to teach them how to assess their feet and care for it as well. Encourage healthy habits. Monitor your lab values that I mentioned before. Now for your evaluation, did your interventions work? Are your blood sugars within normal range? Did they fluctuate? By how much? Do they understand the education that you've given to them? Are they eating healthier food, making better decisions about that? Are they infection free? Was the education successful? Were they able to teach back to you successfully? Were the lab values within normal levels or within normal range? Now let's break down the insulin, because this was tricky for me. So we have your rapid acting. And in this instance, you want to think rapid response, right? So these are going to be the ones that are fast acting. These are going to be taken 0 to 15 minutes before a meal. So think of the mnemonic ready, aim, poke, in, diet. What this means is get ready, aim the pen or the syringe, and then inject them right when the diet or the meal arrives or just before. Now for me, a mnemonic that I used when I was in nursing school was rapid response, don't lag behind. So when there's a rapid response, we don't want to lag behind. Lag standing for Lispro, Aspart, and Glargine. So that is how I remembered those rapid acting medications, or those rapid acting insulins. Now you also have your regular or your short acting. You want to think regular wait time. So you want to give this the regular time, which is 30 minutes before you eat. It needs a short head start. So the mnemonic ready, wait 30, then refuel can be helpful. Get the insulin ready, wait 30 minutes, then you eat or refuel. And in this one, it's going to be your R meds, your Humulin R and your Novolin R. And then you have your intermediate acting insulins, which is going to be, for this one, you're going to think needs planning for half the day. Now, this provides background coverage for about half the day, usually given twice daily, often in the morning and evening. It's cloudy and it needs mixing, so just remember that. So this mnemonic is going to be noon and night. It's a simple reminder that this needs to be taken twice in the day, covering parts of the day and the night. So, or another mnemonic could be intervals equals twice. So intermediate is given at intervals twice daily. The next one we have is long-acting and ultra-long-acting insulin, which you will need to think long-lasting. So it provides a steady background coverage for the whole day or longer. It's usually given just once daily. The mnemonic lasts all day. Once you take it, no peak, go steady. So if you look at it, you'll see the word long. Lasts, L, all day, once, O, you take it, no, N, peak, goes, G, steady. So lasts long, taken once, generally no major peak. It provides steady background control. So another mnemonic is, this one's more simple, lazy long lasting once daily. Lazy long lasting equals once daily. So in summary, rapid and regular will be 4 meals, and it's given before or 30 minutes before eating. 15 to 30 minutes before eating. Intermediate and long are for background coverage. So you have to give it twice or once a day, regardless of the meals, for steady control between meals and overnight. So yeah. So hopefully that helps. These are your common nursing diagnoses. You'll see a lot of risk for
dancing dingledore.
Activity intolerance can be one, risk for injury, deficient knowledge, definitely, because most likely they aren't being compliant or this is a new diagnosis for them. So just assess and get in where you fit in, assess your patient and see where they fall in this, and also consider any other comorbidities that may affect the diagnoses or may have caused them to become a diabetic. And now it's time for an NCLEX question. A nurse is caring for a 52-year-old male client with type 2 diabetes mellitus who is conscious and oriented. The client reports feeling shaky, sweaty, and having heart palpitations during morning assessment. A point of care blood glucose reading reads 60 milligrams per deciliter. Which of the following actions should the nurse take first? A. Administer the client's scheduled dose of metformin. B. Give the client 4 ounces, 120 milliliters of orange juice. C. Recheck the client's blood glucose level in 1 hour. D. Document the findings and continue routine monitoring. Select your answer. 15 seconds on the clock. If you selected B, give the client 4 ounces, 120 milliliters of orange juice, you are correct. This is the rationale. So, in case you are just listening and not watching, I'll read it for you. Rationale. The client is exhibiting classic signs and symptoms of hypoglycemia, shakiness, diaphoresis, palpitations, confirmed by a low blood glucose reading, 60 milligrams per deciliter. The priority nursing intervention for a conscious client experiencing mild to moderate hypoglycemia who is able to swallow is to administer 15 grams of a fast-acting simple carbohydrate. 4 ounces of orange juice provides approximately 15 grams of carbohydrates. Option A is incorrect because administering metformin, an oral antidiabetic agent, will not rapidly increase the client's blood glucose and is not the treatment for acute hypoglycemia. Option C is incorrect because while rechecking the blood glucose is necessary, it should be done approximately 15 minutes after administering the simple carbohydrate to evaluate the effectiveness of the intervention, not as the first action. Waiting for an hour is too long. Option D is incorrect because the client's symptoms and low blood glucose require immediate intervention to prevent further declining. Simply documenting and continuing routine monitoring is unsafe. Thank you all for watching, and I hope that this helps you in your NCLEX studying. Mr. Rodriguez, did we help you any?
Yes, you did. Thank you so much, you guys.
Good. Well, thank you all for watching, and I'll see you in the next one. Bye-bye.